Very much, sir, and thank you for continuing the conversation and your tips while the glitch was there. This is Microspherophakia, and I would like to draw your attention to this very rare anomaly, but once in a while, once in a lifetime, you are going to face this, and what we would be doing now and what we would be doing then is what I'm going to discuss today. So it's very important for us to know that microspherophakia we must not miss on the slit lamp, and a full examination needs to be done right from the fact that this is associated with systemic anomalies, and these patients can have Alprots, can have Loeys, can have homocystinuria, can have Marfan's, and the systemic condition and a proper physician checkup is mandatory, because it's not the eye only, but it's also the systemic features that might be a more difficult situation for the patient. So when on the slit lamp, a microspherophakia comes and you have examined, and this is what the view is. It's like the ring of the edge of the microspherophakia that you would be seeing very, very well. And then you know that the anteroposterior diameter of this eye, of this lens, is much larger than the horizontal or vertical diameter. And this is an important aspect that we need to take care of. And look at this. This is a brilliant ring that you're seeing there. And during the surgery, you know that these surgical aspects are fraught with dangers. So what are they? There could have been an intraocular pressure rise because of crowding of the anterior chamber. I've had cases, in fact, I'm going to show you two sisters of the same family. And another sister of this particular family also had a lens corneal touch when she presented to me. So there are many ways that the presentation can be, but in this case, we are going to show you that what is the most difficult part of the whole surgical procedure in a patient with microspherophakia. And the surgery has to be done usually quite early. As you can see, this is nearly a clear lens. And these are conditions where a clear lens extraction needs to be done. Otherwise, this spherophakic lens is going to impinge on the periphery, and there's going to be a block, and the intraocular pressure is going to raise. So the most difficult part is puncturing this anterior capsule, which becomes the most troublesome and the most difficult part. And you can see that I'm using a counter technique to get that 26 gauge needle inside, because nothing is going to help puncturing this. So first puncture can be very, very difficult. It's like a deflated balloon, and a needle also has to have a counter traction. The next part is making a curved and a circular capsulorhexis, which again is difficult. You saw it in just about 5 seconds, but this one took me at least 15 minutes, because every time I was doing one part, the other counter traction had to be given by a ball dialer, and then another part, and then another part, and again refilling and filling with viscoelastic. You cannot fill too much also, because then the intraocular pressure can rise and you might have a runaway if a little bit of visco comes out. So the important part is doing this capsulorhexis, and it has to be neat circular. If the capsulorhexis runs out, it's finished. You just hand it over to your VR surgeon. So the next part is getting in those hooks. Now here, the capsular hooks will not work. And what is important is these iris hooks. Because of the short flanges, it's important. Here we are putting in the single piece intraocular lens. And again, as we understand that this bag, if we do not attach it and fixate it, it's going to definitely in the future, it's going to either come up and there could be a synechia, or it could decenter, and then you would have problems and maybe even have to remove it. So fixation of these bags, because the zonules are deficient, is mandatory. And here, the CTR will not go in unless you have a customized CTR, because the spherophakic bag is so small. What's important is these AMED segments. Now, you can see that the AMED segments itself nearly circumferentially are going to support nearly the whole bag. You can see the ML segments there. And here we have the flaps, 2 flaps in each part to fixate the ML segments. And with the fixation, this is it. So these are the 2 eyes of the same patient. One eye shows a lot of fibrosis, which was there. The other eye was much better. And but the vision in both these eyes were all right. Now let's look at this next sister. And this lady presented to us quite late, about 5 years ago. And we are going to do something that the femtosecond laser definitely gives a big advantage. And here, the capsular axis is the only thing that we are going to do with the femtosecond laser. And you can see that it's a spherophakic bag in total. So you can see nearly the sphere that there is. You can see that it's nearly a round lens. And what we just need to do, and you can see the shallowing of the anterior chamber as well. So we always have to make a rhexis which is much smaller. This was possibly a 4.8 millimeter rhexis. And here you can see the rhexis now. So with the rhexis, you can see it is also not a full circular rhexis that a femtosecond laser does. Now this was my first case, and I want to show you this because again, all the parameters have to be set so that we have a good rhexis, but this is a postage stamp rhexis that we have made. And we'll do the Hoffman's pocket for this patient, which is a more elegant way of doing a fixation part. And with the Hoffman's pocket, and then we go in giving it the main port, and the rhexis has to be very, very gently taken off. And this also can run out if you're not gentle, because you can see that all those little postage stamps have to be actually negotiated to have this rhexis come out. Now, very gentle hydrodissection, and again putting in the same iris hooks. This nucleus has hardly any nucleus, and you just take it off with this. Just 1 more minute, sir. And then once that is done, the fixation is again important, and a single piece lens can again be placed in. So with the single piece lens, these patients, which are usually high myopia patients, can get a very good vision, and that's what we want. And you can see that the haptics of this particular single piece lens is so soft and well into the bag that it crowds in, and it actually circumferentially helps the bag retain its shape very well. And again, the same AMED segments can go in. With the AMED segments, the importance of having a proper maintenance of the whole area is very, very good. And once the fixation is done, the fixation again has to be very proper. The tightening of the sutures must be very good so that it tightens well and just optimally. And you can see that it is crowding into the pupillary area, but nevertheless, one has to have the fixations in place. So thank you very much for your patient hearing.
That was a wonderful talk by Dr. Partha Biswas. So a lot of gymnastics done in that small capsular bag.